Thank you to all our esteemed judges and speakers for this wonderful session on cancer pain. Now we'll move on to the next session, how I do it.
Our How I Do It session brings together the masters of pain management to share their secrets, techniques, and expertise. Our expert faculties will take us through their step-by-step approaches, sharing the nuances and tips that make all the difference. To chair this session, I would like to invite our esteemed chairs, Dr. Sudeshna Thapa, pain physician and anesthesiologist from Nepal Pain Care and Research Center, Kathmandu. Dr. Archana Yadav, consultant pain and anesthesiologist at Nepal Police Hospital, Kathmandu. And Dr. Piali Mandal Basak, specialist in neurorehabilitation and interventional pain management. Now I would like to invite Dr. Snehal Panchel, in charge of Pain and Palliative Clinic at Holy Spirit and Bhaktivedanta Hospital, onto the dais for her presentation on tendo Achilles calcification barbotage.
So, good afternoon, everyone. First and foremost, I would like to thank everyone who is sitting here, because this is the last session, and I guess there is too much of academic bombardment since the past 2 days, and I'll try to make it as simple and as fast as possible so that you can proceed with your further programs. So actually the topic given to me was, firstly at the outset, I would like to thank Gautam Das sir, Dr. Sushpa, Dr. Smriti and the entire team for arranging such a wonderful conference and giving me an opportunity to present my case. This is of course a video presentation. So it was on tendo Achilles tendinopathy. So it's also called as Haglund's deformity. It's an abnormality of the bone and the soft tissues in the foot, where there's an enlargement of the bony section of the heel where the Achilles tendon gets inserted. Can you play it? Yeah. So I have tried to make it with some music and as a video so that it doesn't sound very boring. So the predisposing factors are, first is foremost, it's idiopathic. It can be idiopathic, there can be no cause. There can be certain genetic cause. These are patients who have especially high foot arches because of the tilting of the heel backward into the Achilles. They can have, there can be predisposing factors, there can be injury, improper footwear, over practice, like repetitive stress, altered biomechanics, which with subtalar joint malalignment, and increased weight, which adds to the mechanical stress. And what are the signs and symptoms? So there is a noticeable bump, so which is an enlarged prominence at the back of the heel. There is heel pain, constant pain, okay? And there can be some redness and swelling. And why does this happen? There's continuous friction between the soft tissue at the back of the heel and the shoe, and which can cause the bursa to be inflamed, okay? And there are certain differential diagnoses which are common for the back of the heel pain, which is tendo Achilles tendinitis, retrocalcaneal bursitis, retroachilles bursitis, plantar fasciitis. So physical examination includes bursa, tendon, calcaneus examination, functional tests. There are certain functional tests like hopping on the toes, X-rays to identify a bony protrusion, ultrasound which helps us in identifying the pathology of the bursa, and MRI can be used, but I think ultrasound itself is fine. So this was a lady who had come to me. She was a 48-year-old female and she complained of pain in the back of the heel, and you can appreciate. This is the marker. Okay, so there is a nice spur and there's some calcification there, okay? She tried ultrasound and physio. So this is a bump, okay? It's called as pump bump because this is the pump muscle and then there is a bump here, okay? Okay, this is a wrong slide, sorry. So we did the PRP later. So this is how the patient was painted and draped. Because it was a hard calcification and I knew I wouldn't be able to do myself. So I had a radiologist friend who helped me to hold the probe. It started with, we just used a sterile technique, and I gave the local anesthetic injection, okay? So you feel for the bump, and just above it, I injected some local. Okay, so you aspirate and inject some local anesthetic. Okay, then, so you can see the needle coming here, okay. So this is the needle, which was a 16 gauge hypodermic needle, 1.5 inch. We started insertion inside after giving the local. And this is a nice bump which you can appreciate, okay. So it was little difficult, but we could manage breaking the calcification. So sometimes if they are not soft calcifications, it becomes very hard to break it. Of course, this was not so hard. So you can see we could nicely break the calcification. We tried to do some barbotage, saline barbotage also with it. So you have to check, keep on toggling the probe and check it, because sometimes we feel you may have broken the calcification, but some part could have been left behind. Okay, so you can see it's almost getting done. So there's something at the tip left, yeah. There's some amount of bursitis also here. Okay, so this is saline barbotage I started doing. There was some part still left. See, when we changed the probe position, we could appreciate some part of the spurs still left. One sec. See, some part was still left. So again, with the saline, I tried to do barbotage, okay. So you reconfirm, you can make the probe position axial again and check it again. If you feel some part is still left, you can again, repeat the same technique. Okay, now it's looking little fine. Okay, yeah. Yeah, see, we could break it actually very well. Yeah. So I routinely use this TubeX kits. These are the PRP kits. So we collected around 20-25 ml of the blood. We put it in the chamber and then put it for the centrifuge. So we usually use a double spin method. So after the first spin, we actually and then you rotate and get the PRPs concentrate up and again put it for the second spin. So this portion, the PRP gets collected usually. So second spin. Okay, and Okay, so the supernatant, which is plasma, which is removed, and then the PRP is collected. Okay, it's sterile precaution. This is the long needle which we use. Yeah. So I had told him to give me a little more volume because I could see some bursitis also there. So I was planning to inject a little there. So he gave me around 3.5 ml. So this is the plasma which was collected, the PRP. And then again, under X-ray vision, okay. Yeah, so okay, you can see some fluid being injected here. Yeah, see you. Okay, thank you very much.